Session 10 is a really important topic of continuity of patient care. We reviewed different barriers that make it difficult to care for patients without interruptions in primary care, as it relates to access, delivery, and maintenance of relationships between patients and physicians. Next, we discussed the topic of time horizons and how much skin in the game different stakeholders really have as they engage with patients over their lifetime.
One of the issues with patient mobility is not so much that we don't have the technology today to keep up with our patients no matter where they move. It's mostly a state licensure issue. Every state has their own license. And in order to practice medicine, you have to go through the process of getting a license in every state. Are there major differences in training? No. Are there major differences in standards? No. Did a lot of the states relax their rules during COVID? Yes. Why are there still 50 different state licenses? Who knows, but it makes some people a lot of money, and that's probably a good reason it still exists. The other big issue is insurance coverage. In traditional fee for service, or even in the employer space, because that can count since many people get their insurance through their employers. If a patient changes employers or switches insurance products, they might not be able to get to the same primary care. In a direct primary care setting, finances, because patients have to pay themselves, sometimes a lack of finances may be a reason they have to leave the practice. The other thing is currently under investigation by the Federal Trade Commission, which is non-compete clauses. Most hospitals and private practices will have some sort of non-compete clause where doctors cannot practice within a certain radius if they leave that practice. There are a lot more aggressive hospital systems that will say you can't practice like 25 or 50 miles out from any center that the hospital owns. Many times this means you either work for the hospital system or you move to another state where your patients generally cannot follow you even if they wanted to. Those are the main barriers that keep continuity between doctor and the same patient. The other one, which is more of a technicality, is scope of practice. In the old days, primary care doctors, family medicine used to be able to see their patients in the clinic, see them in the ER, and then admit them to the hospital and see them in the hospital. But nowadays, hospitals generally will not allow outpatient primary care docs to admit their own patients. And with the rise of hyperspecialization, including hospitalists, which are doctors who work only in the inpatient hospital setting, which, by the way, is kind of a new position that started in the 90s. They started off with family medicine doctors, but now it's more internal medicine doctors that staff these, as well as the specialty of emergency medicine. There's a lot fewer family doctors in emergency rooms and in hospitals. And in fact, many of the larger hospital systems and more urban areas don't even allow family doctors into those settings. The next important thing about continuity of care is how long does continuity matter? And we call that time horizons. So, who has the longest time horizon? Generally speaking, it's the patient because the patient is with themselves for their entire life. So the decisions they make and their health matter to them the longest. Next would be family members. Family members want their loved ones to be healthy, want them to stay around a long time. So as long as the family member is alive, they want the patient to stay alive or at least stay healthy and functioning. Next would be the employer for as long as the employment lasts. Every employer wants a productive workforce, and a productive workforce begins with having healthy employees. But this is where the time frame gets a little shorter because the average employee only stays with an employer for about 4 years. Next is insurance companies. And this is pre-Medicare. Not talking about these Medicare Advantage things. Pre-Medicare. The average beneficiary will stay with an insurance company for about 2 years. MA is a little different, and that's why some of these insurance companies are a little more excited because generally when a Medicare beneficiary picks a product, they will stay with it for the rest of their life. Of course, the life being starting from 65 onwards, which is greater than 2 years generally. And then, interestingly enough, there's the health tech and VC world. Generally, private equity will try to get returns within 5 years. They want to get a lot of profit and then move on. What's interesting about these time horizons is that even though the patient has the longest time horizon, they might not be the most motivated or the best leverage to deliver the highest care. What that means is patients generally will do what they want. You look especially at males who refuse to go to the doctor unless their arm's falling off, generally dragged there by their loved ones, family members, but they do have the longest time horizon. You move to an employer who only cares about the patient for about 4 years or however long the employee is employed. And of course, this is changing with gig workers, but they only care for 4 years. They're not going to try to prevent the stroke or heart attack that's coming 20, 30 years down the line. They just want to make sure the diabetes is controlled enough so their employee is not constantly in the ER for complications from diabetes or they're constantly calling out sick with infections. Insurance companies, even less, with their 2 year time frame, they're really focused on maximizing their profit now. If this patient leaves in 2 years, any sort of preventative measures won't matter. So they optimize for the short term. It's pretty fascinating to see the discrepancy between who has the longest time horizon and who has the highest motivation and the most leverage to truly practice preventative whole health care for the patient. As this session started, I mentioned how continuity is important because you get to know the patient better. But the larger question, or perhaps a finer detail, is does a single person need to have continuity, or can a company, for example, One Medical, be the continuity? And Paulius and I will discuss some of the pros and cons of either.
To summarize, we reviewed several factors that make it difficult for doctors to take care of the same patient panel over a long time. We discussed reasons for why not all stakeholders that interface with patients either directly or as entities supporting care delivery share the same long term outlook on the health and well being of patients. This concludes session 10.